Professor Namrata Sharma. She is going to talk about her most favorite topic, that is a paradigm shift in dry eye management. Over to you, madam.
Amit, in the meantime, Dr. Namrata is getting ready. What doses schedule you advise for this psychosis?
Dosage.
Yeah.
At least a year. I mean, you
6
have
months
to
and
use
beyond.
at least more than 6 months for the total effect to occur, and we should not stop. We have started it already 6 months or 1 year. We have to continue for a long time, and as I mentioned, there's no systemic side effect and there's no ocular side effect. So we should continue for a longer duration.
Thank you. So, a dry eye treatment has been ever a challenge from times to time, and now we have Professor Namrata Sharma. She'll be talking on a paradigm shift in dry eye management. All over to you, ma'am.
Thank you. Dry eye disease, if you look at the prevalence, and there are a couple of studies, one from Eastern India and one from North India. North India was done at our center. So from Eastern India, the incidence has been reported between 18 to 54%, and from North India, 32%. And this was also a study which was published much earlier. So I feel the dry eye disease incidence is actually much more than this. And this was in the hospital. That means it was at a tertiary eye care center. Both of them were tertiary eye care centers, but in general, I think it is much more than this. So this is the study which was published, and we looked at the moderate and the severe dry eye disease incidence, and we found that close to 30% of our patients were having dry eye disease. Very nicely, Amit has summarized that inflammation is the pathology in dry eye disease, and so it is important that you control the inflammation, which can be done by anti-inflammatory therapy. Currently, we have cyclosporin, tacrolimus, lifitegrast, 3 drugs which are available. But cyclosporin remains the one with the longest track record as of now, and also which was the one which was available to us the earliest. The mechanism has been talked about, so I will skip this part. Suffice it to say that you need to give topical cyclosporin because you need to break the vicious cycle which is there of inflammation. And in these cases where inflammation is there, you can start with the topical steroids and then give topical cyclosporin as well. And then because topical cyclosporin starts to act, it begins its action of onset of action in 6 weeks, and then the action is maximum at around 6 months. So it is important that you start it with topical steroids, so that when you are tapering the topical steroids, this kind of takes over. So these are the steps at which it should be started, and when you have stage 2 or grade 2 dry eye, then you should start the topical steroids, and they have a role to play, and so also the topical cyclosporin. Now, response, if you see, like I said earlier, initial 1 month, the maximum response comes in 6 months, but it starts to act at about 6 weeks, and so one has to be compliant with it for its complete action, onset of action. There are various oil-based formulations which were there earlier, and it can be with preservatives and even unims, but cost effectiveness remains an issue there. Oil-based emulsions will have decreased bioavailability and may cause more stinging. Benzalkonium and ethanol have its own cytotoxic effect, especially on the conjunctiva and the corneal epithelial cells, and so will disrupt the epithelium. And this mechanism, I think, very nicely has been highlighted in the video, so I will not talk about it, except for the fact that it comes in a different kind of a bottle, which is a preservative-free multi-dose eyedropper, which avoids the need for preservatives and prevents bacterial contamination. There are non-return valve, which ensures that no contaminated liquid can be reintroduced into the container after the drop has been dispensed completely. And it also has the basis of pure flow technology, which means that the intake of air into the dispenser takes place by separate venting system with the silicon membrane, which is called pure flow technology. and then the drops are calibrated. So it is going to be neither more nor less, but about 40 microliters. So this is how the bottle looks like. If you look at the meta-analysis of the randomized control trials on topical cyclosporin for dry eye disease, it is very clear that it does improve the tear breakup time and also improves the fluorescein staining score, and these are the results from therein. Now these are the various topical formulations which are available and which have been reviewed in literature as well. And this is just to see, to assess the prognosis of dry eye with patients treated with cyclosporin A or with artificial tears, and also to assess the reversibility of the benefits of cyclosporin A after switching the treatment dry eyes to patients to complete 1-year course with artificial tears, etc. And it was found that even after you actually take it off, some amount of effect does remain for a good amount of 3 months. And so when you are putting the patients back on cyclosporin, you should always at least follow them up for 6 months. This is the study which was done at our center, role of 0.05% topical cyclosporin, the cyclisis PF, which comes from INTAS, and this was a prospective case series of 80 eyes of 40 patients, and these were the baseline parameters. The subjective symptom scores did improve, and also the Shermer score, conjunctival staining score, and the tear breakup time. And you can see that all these parameters are significantly different. So these are some of the results from there. So this is a case which was inflamed, and after treatment it does become non-inflamed and there is no staining. Then impression cytology did show that the goblet cells became optimum after the treatment with cyclisis PF, and this is yet another case which healed on topical cyclosporin 0.05%. This was a one-night patient with dry eye which was treated, and this was yet another patient with rheumatoid arthritis treated with cyclisis PF with good results. So in our study, the results that I showed you were the interim results. Now at the conclusion of the study, the results have been reanalyzed, and basically we looked at 50 patients with dry eye disease twice a day used for 12 weeks in addition to the conventional treatment, and we looked at the parameters at day 0, day 30, day 60 and day 90. And क्या हो रहा है? एक सेकंड स्किप करना पड़ेगा इसको, लगाना पड़ेगा। अब देखो, ये है HTML. So basically this was a prospective study of 50 patients and 100 eyes, and we used cyclisis PF in these cases, and patients more than 18 years of age with OSDI more than 18, tear breakup time of less than 10 seconds, tear meniscus height less than 0.25 millimeter, Shermer test of less than 10, they were included in the study, and the exclusion criteria was if they had any inflammation or who were not willing to follow up.
I think before they just connect a couple of questions, I just heard most of Madam's presentation that for every severe dry eye, she starts with steroids. So what is the preferred steroid you use in dry eye management, Madam?
So I don't start with the topical steroids, but if there is an inflammation, then I would give topical steroids, and
Which one?
we'll give a
Prednisone?
low dose topical steroids
Oh.
first, and then subsequently add topical cyclosporin.
Some of your previous talk I heard that in severe dry eye you started prednisolone also.
Yeah. So moderate or severe dry eye is different. There you would want to start with the full-on steroids, that is prednisolone. But for mild dry eye, one can start Lotepred or FML, although I firmly believe that those, really don't help much. When you have to start steroids and when you are actually thinking of breaking the vicious cycle, then you have to give it full on.
My next question, all your refractive patients, sir, do you start cyclosporine?
So all our refractive patients, we did not start cyclosporin, but there was a study which was conducted again at our center which showed, and up to 6 months follow-up, that all the refractive surgery patients.
Yeah. Madam, you can just continue.
No, but where is it? Okay, I'll have to. Okay, I'll just एक minute इधर. So I think I've already talked about the exclusion criteria. Next slide, please.
Next slide.
No, we can finish it. Don't. There were 27 male patients, 23 female patients, and most of the patients were from urban population because that is our population which is generally there. And these are the results. If you look at the tear breakup time, the Sharma test, the lower lid, the tear meniscus height, the lipid layer thickness, the non-invasive breakup time, and the corneal staining as well as the OSDI. So in all the parameters, you can see that there is a difference which was statistically significant. And for instance, tear breakup time from 2 at baseline increased to 5.4. Which is quite a jump. Likewise, Sharma from 7 to 11, and likewise for the other scores as well. So this is again just to show that from 2 it has increased to 5.48, and at all follow-up points this was statistically significant. Likewise, Sharma from 7 to 11, again a statistically significant improvement, and the lipid layer thickness increased from baseline value of 31 to 38, which was also statistically significant. And although even tear meniscus height, it increased from 0.18 to 0.24, which is near normal, and so was the non-invasive breakup time, which also statistically improved. In terms of corneal staining also, which was graded, there was improvement, and the meibomian gland loss in the upper lid and the lower lid at the baseline, which was less, also at 3 months it increased. And after 3 months follow-up, it did not change. Ocular surface disease index, again, from 28 came down to 16, which was statistically significant. And on follow-up at 1 and 2 months, there was a statistically significant improvement in the OSDI score. So there were no adverse events as far as the safety is concerned. 5 patients did experience mild adverse reaction in the form of slight stinging, but no patient discontinued the drug, and all the patients, they followed up their, all the patients completed their follow-up. So to summarize, there's a consistent improvement in the patient comfort and satisfaction with the use of preservative-free cyclosporin 0.05%. All the parameters did improve, which I have already discussed, and this cyclosporin 0.05% preservative-free aqueous-based solution with novel proprietary lipid technology does enhance the drug bioavailability and help in the targeted drug delivery, and helps to decrease the time to symptomatic relief, and has improved tolerability, mainly because the formulation is done at pH 7. Novelia multidose closing tip system is the crown, or is the added advantage, and this should be used and can be used for patients of dry eye. Thank you so much for your kind attention.
Thank you, ma'am. Ma'am, just one more question. What is your experience what is the general tolerance level of people who are using this drug? Do they really feel stinging, or they are just as comfortable as other normal drugs?
So, like I said, 5 out of 100 here, so it was 5%. But this was a prospective study, and we asked for it, because as per the performer, we had to ask for it. But in case, if you don't ask for it, then maybe there are fewer patients. I mean, at least with this, not talking about
with this
others.
aqueous-based one.
Especially with this, not talking about others. But in the prospective study, the stinging or the burning sensation was 5%. But you have to advise them to put a lubricant first, and wait for some time, and then put the drug in case there is stinging. One is this. Second, you can also ask them to cool it a little bit. That also causes less amount of stinging.
Now, supposing we take this medicine for moderate to dry eyes or those who are really having an inflammatory component. So if today is day 0, by how many days the relief starts coming to the patient? Is it day 15 or 30? What do you feel? What is your experience?
So in general, I think it takes about 6 weeks for the onset of action, or maybe 4 weeks for the onset of action,
4 weeks.
because this is a preservative-free technology. But I feel stinging is also less because of the preservative-free effect.
Okay. So what we conclude is that there is a good amount of acceptance for this aqueous base as compared to the oil-based drops. Okay.
oil-based.
Thank you so much.
Even the pH of this formulation is 6.9.
7.
So yeah, 7. So that's also one of the reasons why the stinging is less.
Thank you, Dr. Rajesh. I think now I invite Professor Rajesh Sinha to talk on.
Yes, you have one question, ma'am? Yes, please.
Yes.
Chronic disease, and the effect comes at nearly 6 weeks, and the dry eye is continuing. So supposedly we give it for 6 months and we give a break. Then how long should we give the break and then again begin, or should we give it lifelong? What should be the longer
So we have
protocol?
given, I have patients who've been using this drug for 5 years plus. But what I generally do is that I would like to give them, give this drug to them for a year and then give it a break. And I would give it a break for at least 3 months, because what happens is that once you've given cyclosporin, the residual effect does remain for the 3 months. So even if you stop it today, for about the next 3 months it will remain. So to say that you don't need it, you should follow up the patients for 3 to 6 months.
But in general, we presume that if a patient gets benefit from cyclosporin, he is a lifelong patient for cyclosporin.
No, some patients are there who are not adhering to the dose. Rather than twice a day, they'll just give once a day and still be happy with it. So you cannot say lifelong. If you want to stop it, you can think
Few
of stopping
breaks.
it at 1 year and then see how it goes. Because basically this is also breaking that vicious cycle which is happening. So once you break that vicious cycle which is going in circles, then it kind of puts a break to it.
Thank you.
Yeah.
So
Okay.
recommended is that you give a break after 2 years, if you ask me.
Better to crush the disease, yes.
Yeah, if you see the literature says you should give a break after 2 years.
Okay.
I give it after 1 year, because see, for us it is a little different. We use it a lot more for allergic diseases also.
Yes, ma'am.
We don't use it only for dry eye.
Yeah.
So for allergic eye disease also we use it quite a lot. We use it in number of...
Even for VKC also?
Huh?
VKC also?
Yeah, for VKC, for graft rejections, for
Graft rejections.
allergic eye disease, for dry eye,
Yeah.
for adenoviral keratoconjunctivitis, nummular opacities to disappear.
Mm.
People
it's
use
a
it
wide
for
spectrum.
keratoconus also, so that they don't do eye rubbing and it doesn't.
Exactly. Thank you, ma'am. Thank you so much.